Okay, now we're going to be talking about this group of internal rotators. Remember, we're in this section of non-pathologic left AIC treatment mode. So let's get back into that. What did we just get through doing? We repositioned somebody. We went after hold control on the right side. Got their glute max to co-activate with the adductor magnus. Thank you very much, Chad, for picking those activities up. And Pat, we got that. We got the right glute max, right adductor magnus. Now we're going to switch into high plane internal rotation games, okay? Lots of internal rotation. Which side? Which side, guys? Left. Now we're on the left side. We're switching over to that left side. So here are 3 techniques that all would involve the left side. Left IR, okay? 3 of them. And at this point, Jen, I think what we should do is pick that first one. Don't you think? And that would kind of kill some of the things we talked about at lunch. So Drew, I'm gonna pick on you. I told you, all hands off right now, Drew. We'll get you up here. We'll put you on your right side. If you take your shoes off, we'll put you on your right side, just for our wall's sake, and we'll put a ball there. And Drew, if I could ask, who would like to, Eric, would you read for me a little bit? You're gonna go to, that's on page 39, okay? What are we gonna do here? What's this called? What's this called? Eric, what's the name of the technique?
Right side lying supported left glute med.
What does the wording mean? Let's see if Jen can help you out there. Jen, while I get my cup of coffee in my mouth, what does that mean? Jen did all the labeling about 4 or 5 years ago. No, maybe longer. How many years? 5 years ago, Bobby and Jen and I sat down and we had to make sure things we would never regret in terms of how they were worded. So the titles for all these mean something. This is the introductory course, so we got to let you know that. So Jen's going to tell you what these titles kind of mean. Let's just look at these 3 titles.
Well, the first part of the title is just what side they're going to be laying on, or if they were doing standing. But the supported means that you either have at least 1 foot on the wall supporting you, so you're not doing a completely open kinetic chain activity, or you have 1 hand on a table, or if you're standing, standing supported, you might have a hand on the table, or you might have like your low back against a wall. So anytime you see the word supported, you have some sort of support. So right now the support is coming from the wall, which could be the floor if you were standing upright. So that wall is kind of acting like the floor. There's other words. You'll see some techniques that have the word respiratory in them. That means that there is a specific inhalation that goes with a step of that technique. So if you are inhaling, for example, there's going to be a technique coming up here that he's going to do when we get to the pathological section. A right side respiratory, left adductor pullback. Every time you inhale, you're shifting your left knee back into AFIR. So if you see the word respiratory, you know that there's an inhalation phase that goes specifically with a step in that activity. Otherwise, kind of the descriptions come along with the CDs that you purchase. But we give you guys a massive handful of techniques in the appendix of this manual to get you started for those of you who are new in the room or who are taking this home study for the first time. You have a large chunk of techniques to choose from in this appendix. But like Ron said, 5 years ago, we could put together 3 different CDs, 1 for each primary course, and they are organized by the facilitation muscles and the inhibition muscles. And there are over 500 techniques on each CD, including the integration section, which is on all 3 of them. So there's definitely a lot more than what you got in this manual, but this manual will get you beyond started.
So a lot of effort went into this. We just don't want you to think that these titles we just came up with overnight. I mean, it wasn't a painful ordeal, but it was a very long ordeal. We want to make sure it's done right. So this says right side lying, supported left glute med. The foot that's on the wall is kind of giving him the identity that he needs for that support. So that right foot's on the wall. That right foot's going to act as a whole controller. And we're going to have Eric do the reading, okay? Eric, so go ahead. Tell us what to do.
All right, step 1, lie on your right side with your feet on a wall.
Okay.
Hips and knees at 90-degree angle and your back rounded.
All right, he's going to get a little closer. Another 90-90 position. Thanks, Drew. Okay, check. He's there.
Place your lower
His
arm.
feet stink, but he's still there. Go ahead.
Place your lower arm or a pillow under your head and upper hand on the floor in front of you to help stabilize your trunk.
Check.
Place a 4 to 5 inch ball between your knees.
So we got this little ball, and we're going to put it between the knee, okay? Let's just remember, a ball between the knee activates what musculature? Internal rotators, or deactivates external rotators. I did that, Eric. What are we going to do now?
You're going to push your right foot into the wall.
So I'm going to have him just gently, firmly place the right foot on the wall and know it's there, right? Relax, and do it again. So, do you feel that, Drew? Relax, and do it again. Folks, he's probably going to do a good job of repositioning himself if he does this. Relax. Excuse me. Take a deep breath in for me. Blow out all the air. Push into the wall. Hold it. Breathe in. He probably just repositioned himself because he pushed his foot on the wall when he took a breath of air in. And since the ball's between his leg, I know this inner thigh has to be on because he's holding it. And since he's laying on this side and he has whole control on the right. So he probably already starting that whole process, Eric. But let's keep going. What's the next one say?
Slide or shift your left hip back as far as you can without arching your back.
So at this point, I'm not even going to worry about his breathing. Drew, just keep breathing somehow. Stay alive, okay? So I want you to shift this left hip back. And I'm going to guide him a little bit. I may say, Eric, maybe he doesn't know what to do. So I'm going to actually guide him. Do you feel that, Drew? That posterior hip capsule, I'm kind of guiding back. Okay, let's just play with this a little bit. Have you squeeze the ball and slide back. Did you feel the inside of your left thigh?
Yeah.
Okay, push your foot into the wall when you did it. Did you really feel the inside of the left thigh?
Yeah.
Now let go of the wall on the right side. Did you see how it had some impact on the myokinematic position of the left ischiocondylar adductor?
Mm-hmm.
Did you feel that?
Yeah.
So when I get whole control on the right side, the intensity of the muscle that's internally rotating my left side went what? And that muscle happened to be a what? An adductor. But it doesn't say anything about adductor. Let me check. Does it say anything about adductor? No. It says only something about what? Glute med. So Eric, I bet there's more going on here that we got to keep going through, okay? So what does it say next?
Press your left knee down into the ball. You should feel your left inner thigh engage.
Okay, and he does.
Rotate your left thigh in by lifting your left lower leg towards the ceiling.
As he keeps his right foot on the wall, as he pulls his left leg back, now, Drew, what are you feeling right there?
Kind of release and then, no. don't
Yeah,
feel as
it
much.
dropped here, and do you feel the outside of your hip somewhere?
Yep.
Okay, let's go up a little higher, Drew. Okay, how about there? Where are you feeling
Really
that?
on the outside.
Yeah, with your glute median min area.
Mm-hmm.
Go back a little further if you could. Oh man, Drew, could you point to it? Because everybody wants to know. That, Drew, really brought it in, I think, correct?
Yeah.
Could you push in the wall for me?
Yeah.
There, did that shift it even a little more?
It did.
Did it isolate it a little better?
Mm-hmm.
Wow, everything we did brought in the anterior fiber of the glute med and the what? Glute min. Relax. Okay. That's a start, Eric. I think he's on board. I mean, he's kind of slow, but I think he's on board, okay? We got it. No comments. No comments. Okay, here we go. What's the next one, Eric? Is there anything else?
It's our breathing.
Okay, and then you gotta do the most difficult thing in life.
Breathe.
Breathe. Should we do it again, Drew? I'm having fun with you. You doing okay?
Yeah.
Here we go. Push your right foot in the wall. Squeeze the ball a little bit, pull back. That's your inside thigh. Don't let it go of the wall, right? All right, think turn, Drew. Think turn, Drew. Think turn. Turn your femur in by lifting your foot up. Keep breathing. Turn a little more if you can. Right, pull this knee back if you can. Hold it right there, Drew. I'm gonna let go. Squeeze the ball, Drew. Push in the wall, Drew. Keep that foot up, Drew. Feel that hip burn? Keep breathing, Drew. Keep pushing, Drew. Keep squeezing, Drew. Keep turning, Drew. Keep pulling, Drew. Now, Drew, do you feel your left hamstrings kick in? Stop. So if Drew felt his left hamstring kick in, this isn't a hamstring program, Which hamstrings did Drew just kick in by me doing what I did? The lateral ones or the medial ones? Well, he told you it's ischiocondylar adductor because he could feel that. So Drew, did you feel some medial hamstring kick in? So I got it all. I got it all. I got him shifting. I got the posterior capsule. I got him shifting back. He was breathing just fine. And I'll bet things happened all the way through his system with that glute med program. Jen at lunch in a break said, Ron, you got to show him this. And that's why I'm glad we're doing this, Drew. Thanks for showing everybody this. This is really a major, major PRI contributor. So you might want to circle this one. This is called the right side lying. Read it out, Eric, so I don't read it wrong. What's the title called?
Right side lying supported left glute med.
This is really a big one. And you could do this upright. You know, there's techniques in your manual that this will be spread out all over the manual when it comes to glute med in men. So it's kind of a major, major technique. Jen, do you want to comment any more on this one? Thank you. Eric and Mike, if you want to change seats again, you're more than welcome to do so. Drew, you can have a seat. Thanks, Drew. So that's a big one. Now, we're going to have a little lab. You might want to think that's one of the things we're going to have you do. We're going to probably do that. It's called more like an adductor pullback with a little glute med. I brought a bolster up here. I could have put a bolster between his 2 feet, Lydia, and he could have just laid there and not done the last part of that technique. I could have asked him to pull back his left leg and squeeze this ball. By the way, all of you take one home with you. They're yours, okay? Take a ball with you when you leave. I could have had him squeeze that ball and had him just lay there with that femur internally what? Oriented, rotated. And just keep breathing as you push, as you squeeze, as you push, as you squeeze, as you push, as you squeeze. If he couldn't pick up that left foot, maybe I chose the wrong technique. Well, maybe I chose the right technique, but he's not ready for the full technique. I'm just going to do an adductor pullback. I'm going to have him pull back, squeeze, pull back, squeeze. Do you follow me? And that's in your manual somewhere. It's called a pullback. And I could do an adductor pullback with a little IR flavor. Put the bolster between his feet. I'm just getting you to think. We don't really have to go through all that, but you can think of all the ways. What if his hip capsule was so tight he couldn't get it back? I would do a pullback, an ischiocondylar pullback. Pull back, pull back, pull back. He'll never pull back without that right foot anchored on that what? With that anchor foot. Drew, and the type of population you work with, I can see this. You know, I can see them doing this in their bed, or do you follow me, Drew? I really can. So I'm so glad you're here. Are there any questions about that one at all? It's a really kind of a major activity for us when it comes to glute med. It's more of your simpler. Now, what's the difference between A and B? Well, she's laying on the other side. Bobby has a bolster under her left foot. She's doing a pullback by bringing this knee forward. By bringing the right knee forward, she's doing a pullback on the left. Her inner thigh on the left is going to feel this activity from the right. When her right side goes forward, when that glute max activates and she brings this knee forward, that inner thigh is going to pull the pube with it. That inner thigh, the left inner thigh, is going to pull the pube to the left medial knee. And that left medial knee is like an adductor pullback on the left side. But the right leg is now going which way? Forward. Is there really very much difference between this and this? No, it's just a different position. And then she's got this beautiful balloon in her mouth that activates this respiratory system. Because, see, Drew, I could have done that activity, and if I knew you couldn't breathe and you were struggling to do the activity and you just couldn't get it synchronized with your breathing, or you couldn't just breathe, you're just holding your breath, I'd say, time out. Why don't we put a balloon in your mouth? Why don't I make this easier? Why don't I lay you on your left side, move your right leg forward, and now you don't have to pull back as hard. And now all I want you to do is keep that right knee in the air, a little glute max, but I'm still getting the anterior fiber of the glute med. I'm still going to get it. I want you to blow up this balloon. And you'll see as she blows this balloon up and brings this right leg forward, that left outside hip is going to burn. Because the glute max is pushing your hip to the left. And as you internally rotate that left thigh in that position, the only fiber that can do it, Sheila, is the anterior fibers of the gluteus medius and minimus. It's going to burn. This is when I was skinny, and this is me walking around a step around. It's probably as old as I can. I mean, that's a long time ago. I was doing these step arounds. You step up, step over, and you just did these like we call them T-Rex step arounds. And I could have showed you that today. It's a very, very good way to do what you're doing here, down here. This is a beautiful way to get left AFIR with the glute med on the left side. It's the same process. This knee is sort of in a 90-90 position, but this knee, because you're not laying on a wall, but you're rounded. Your knee is forward on the right. It's back on the left. And Bobby is moving her right arm forward for a little trunk rotation. This is a great posture respiration technique that you'd get in that course. The reason it's in this course is because she's got to learn how to shift that leg back, use her glute med to pick this leg up on the left side. Very difficult thing to do. So it's a more elaborate activity. Before I go any further, I don't know, maybe Jen said this. This number D, this letter D, you're not going to find in the beginning of these glute med activities. Remember I said yesterday you've got a standing section, a supine section, a sitting section. Remember that, Mike? And in the standing section, I'll bet you, Jen, this is somewhere in the middle of that standing section or toward the end. In other words, that you just don't pop people up and do this kind of activity. So Jen's reminding me to make sure that we get the basics down first. The basics for this particular example would be, I think, this one. Jen, did you want to add anything? Let's go to the next one, my favorite. This is my favorite group, the ischiocondylar adductors, okay? This is absolutely my favorite group. Right side lying respiratory resisted left adductor pullback. Left side lying foot toward foot. Seated left adductor pullback. Single leg left hip approximation. I have one on your right side, Jen, one on your left side, one in a left adductor pullback position, seated, and one standing. We're going to do the first one. Jen's going to read it, okay? Jen's going to read it. New blood in the... Sheila, I'm going to have you come on up here. We're going to do it, okay? All right? Why are we doing this one? We're doing it to find an adductor, to find a glute med on that left side, to get a patient to feel something they may not have felt with what Drew did. I don't feel my adductors. I don't feel my glute med. Well, let's get the adductor to help it, okay? No ball, I don't believe, on this one. Okay. Jen, what are we doing?
Right sideline respiratory resisted left adductor pullback.
I'll bet there's some breathing going on with this one, Jen. Here we go.
Lie on your right side with your feet on a wall, hips and knees at a 90-degree angle, ankles and knees together, and your back rounded. Place a pillow under your head and keep your back and neck relaxed.
She's doing a great job.
Place an appropriate size bolster between your feet and a towel between your knees. Your left knee should be lower than your left hip and ankle.
So your left knee, Sheila, and you'll do fine. Don't worry about how this you're going to do. You're going to do fine. The left knee should be lower than that hip, and it is. Put a little bolster there to kind of IR her a little bit. Go ahead, Jen.
Place tubing around your left leg just below your knee for resistance.
Okay.
Have another person hold the other end to provide the resistance.
Okay. Got
Push
it.
your right foot into the wall.
Okay, it's the same thing Drew did. It's the very same thing. So you're just going to push that right foot in the wall. Okay, you got it? Relax.
Begin by inhaling slowly through your nose as you pull back your left leg.
So the trick on this one, when you pull back your left leg, and I'm going to let you do that here to begin with a little towel in between you so you slide, but you've got garments on that are going to slide just fine. And let's just practice a little bit. Let's have something fun. Okay, let's just you and I go back and forth. Just go back, forth, back, and forth. Just feel that. Kind of a weird feeling, isn't it? Go all the way forward, go all the way back. Now let's practice. On inhalation, I want you to go back. On exhalation, I want you to squeeze through your mouth. Exhalation through the mouth. Inhalation, I want you to go back. Exhalation, I want you to blow through the mouth. There, you feel that? You're doing a great job. Now we're going to listen to Jen, okay?
So you need to hang on to the band.
Okay. Right foot's going to be on the wall.
Push your right foot into the wall.
Got the band.
Begin by inhaling slowly through your nose as you pull back your left leg. Exhale through your mouth as you squeeze your left knee down into the towel for 3 seconds.
Now you're doing a good job, but I got to stop you. We're going to keep this foot on the wall, okay? Because you're already kicking in a hip flexor. Did you feel it? Mm-hmm. So we got to keep this foot on the wall. Keep this foot on the wall. Push this foot into the wall. Make contact with this wall. Okay. Just don't lose this wall. And all you got to do is don't work so hard. Just breathe in and pull back that leg, okay? Perfect. You did it, Sheila. Very good. Blow and squeeze.
Inhale again as you pull back your left leg further. You will begin to feel your left inner thigh engage.
Do you feel that? Now
Exhale and squeeze your left knee down.
Don't lose this wall.
Continue this sequence until you have completed 4 to 5 breaths in and out. Attempt to pull back your left leg further each time you inhale.
Did a great job, Sheila. Now, Sheila, hold it right there. And just hold it and breathe. Watch what happens to all this when I let go. Isn't that amazing?
Relax your knees back to the starting position and repeat 4 more times.
Do you see what that band did for you?
Yep.
So it'd be like me having you take this right foot off the wall. This band is giving that inner thigh and that glute an opportunity to roll the acetabulum over this femur.
Okay.
Does that make sense? Let's see if we can find your glute med. Okay, you know where the glute med is? It's on the outside of your hip. I want you to keep, that was your inner thigh that you just felt drop off. I want you to feel your glute med by pushing more firmly into the wall with your glute max on the contralateral side. There. Because you were doing something completely different with an ischiocondylar adductor that made you forget about a different plane called the glute max and the glute med, transverse. So here we go. Let's get the glute med involved. Let's do just what Jen asked us to do. Push your right foot in the wall. Do not let that right foot off that wall. Make contact with the left. Breathe in and pull back. And squeeze. Do you have the inner thigh on the left side?
Yes.
Now, do you feel anything on the inside, on the outside of your left hip yet?
Not much.
Not much, okay? Push into the wall. Push into the wall as you pull back and breathe in. How about now?
Yes.
Say it loud because everybody wants to hear it.
Yes.
Do you feel that glute med? I keep working until that glute med was singing a song like no other. So do you see how the glute med could kick in myokinematically when you push this right glute max on? When you use this hamstring, when you use that inner thigh, as you are in a state of internal rotation, the only fiber left is your glute med and min, and it has to kick in. Because we shut everything else off for that activity because you're doing it. The only thing left to do more of would be more internal rotation with everything secured in a vice grip to help you isolate it. You can't get more out of your ischiocondylar adductor. You can't get any more out of your glute max. You can't get anything out of your medial hamstring. The only thing that is left on inhalation is the glute med. Did you feel that? Mm-hmm. Does anybody have any questions about what I just did? I know some of you are tired. Are you guys okay? Did that make sense, Drew? Drew, can you see all these people in a chair, in a wheelchair? They could be pulling this leg back and doing the same thing. They could be pushing down on that wheelchair support system for the foot, doing the very same thing. They could be squeezing and turning that foot out. I could put a band on them as I'm sitting there eating a cookie with them, which they feed you all the time. And you hold that baby and you try to get that glute med to kick in with that lunch you're having when they don't even know what they're doing. You just want to make sure the cookie crumbs don't go in the esophagus, or excuse me, in the airway, okay? So that's a big deal. That's a real big activity, and I'm glad Jen picked it. Does that make sense? Mm-hmm. So Jen, do you want to comment on this one at all? We're done with that one. Thanks a lot. Sheila, wasn't that tough, right? It's different though, isn't it?
Yeah.
Did you see how you can make things turn on and off just with the activity itself? So the activity play with those activities, those recommendations. Just don't read them and do them. Entertain yourself with them. Ask questions. That could be a 20-minute, 30-minute workout, and I charge her for it, and off she goes home. Right? That'd be enough, Sheila, to carry you for a long time if you do it right. If Sheila's doing that so easy, I wouldn't pick that activity. It's too neurologically unchallenging. I pick one that's a little bit more what? Challenging. Okay, let's go on to the next one. And I'm not going to actually demonstrate this, Jen, but we're going to talk about it. These are all hamstring activities. Every one of these are hamstring activities. And quite honestly, Jen and I I think I'm speaking for Jen, we'd either pick this one or this one of these two. And am I right, Jen? Would you pick that one? Which one would you pick? I'm just curious now that I got you on the spot block.
I would be maybe C.
Yeah, I'm with you. I'd pick this one, B. And the reason I picked this one is because with that weight on her leg, you're getting a snippet. She's getting her right glute max to kick in for AFER. She's getting her left inner thigh to kick in because she's doing what you did similarly to that before lunch. And then what you don't see is that she's internally rotating that femur with that weight on to really get the medial hamstring to kick in, which is really what we want. Could she put a ball between that leg? Yes, she could. Could she put a bolster between that leg? Yes, she could. But I really like that activity. I really like that. And she's in a 90-90 position. Look at her body, Eric. It's somewhat flexed. So I know her hip's going to feel transverse plane, a lot of it. It's really a cool, supported, early intervention type technique. And it's page 21 in your manual. I like retro stairs. I do lots of retro stairs. She's shifting back in her left leg. Now, wait a minute. Band around the leg means I'm getting external rotation. You are. On the right leg, which means she's going to have to get into AFIR on the left. You are getting external rotation on the right leg. And that would shift if you moved her right leg up. But right now, we would just do, I get right glute max for this medial hamstring. I get right glute max in the medial hamstring by going up those stairs backwards. And I probably would put the right foot here, the left foot up. In other words, I'd always be going up with the left foot first because of what we're trying to do with this particular program. I like this high guard one, where there's a little roll-up towel underneath that right knee. And as Bobby is rotating her trunk to the left, she's acquiring A on FIR, and as she does that, the weight is going on that left leg. In fact, the more I look at it, we don't do enough of these. And the right knee is going down into that wall. Chad, you did that. Is Chad still here? But he did that. He brought that right foot into that wall for approximation, for that hole control on the right side. I think we're done with that. Are there any questions about, those are just good overall activities for the person that has really very little pathology, Lydia. It's just a really good overall program. If you guys leave right now, including the home viewer, if you were to start off right there and really didn't fully understand whether or not you had pathology or not, Eric, and you were to start right there, Jen, I think you're hitting a home run right off the bat. But since some of your patients are going to come in with some pathology, we're going to go on. We're going to talk a little bit about those people that come in with this extension drop test that's too easy to do, if you will, which is why it's negative up there. So you have the adduction drop test is still positive. You're still going to do some repositioning. And I want to just remind you one more time, you don't always have to put somebody in a 90-90 position for repositioning. There's lots of ways you can reposition as long as the hamstring on the left side is engaging. You kind of felt your left hamstring engage. Drew, you kind of felt there's lots of ways to get a left hamstring engage. But for the simplicity purposes, 90-90 is the best way to go about doing it, okay? In fact, Jen, now would be the time to go to your appendix. If you all go to the positioning program on page 2 and 3, start there first. I see 5 good techniques for repositioning. The 90-90 hip lift with the hip shift. Folks, I could put one of you on that wall, put a ball between your leg, and just have you there, go up and down, Lydia, and feel that hip shift. Do you see that? The arrow is going up on the right, which means the arrow should be going down on the left. And you'd keep more of the weight on the wall with which foot, Karina? The left. I bet you guys are doing these all the time up in Norfolk. I know you are. And then there's that one that says 90-90 supported hip lift with hemi-bridge. Okay, we kind of did that with Dallas, right? Dallas, that looks familiar. Then you have the 90-90 supported hip shift with hemi-bridge and balloon. In other words, Dallas, the only thing different is I put a balloon in your mouth. And I'd have you work on breathing. It's a little longer instructions. You see that? A few more instructions. But Dallas, what a great technique. What a great technique to reposition the upper body, the thorax, and the lower body. So we could have done that. On the next page, we have just what we did earlier with Drew. It's an adductor pullback. I could have put that bolster, Drew, between your leg. Do you follow me? And I said I didn't even have to pick up your foot. Drew, you could take these geriatric people or these people that look geriatric, they're young but they don't know how to move, and even if that's all you did was just give them appreciation for what? Shift, rotate, shift, rotate. Remember the one where the bolster is between the feet. The one on the bottom is a staple, and that is a staple in our program, and we're going to do that today. Where it says right glute max, we're going to come to that one. We're going to do that one. It's coming up. But it's also on page 3 of your appendix. It's a staple. In other words, it's probably the best glute max activity you can do with the least amount of effort in doing it. It isolates it the most. So that left adductor pullback mentality or the right knee reach advancement with external rotation is a staple in our institute. So that's a big one. So I thought I'd just throw you to those pages, Jen, while we're there. Okay, let's go on to what we suggest. Who are these people? Who are the left pathology people? Left SI strain. Circle it. These are the people that really, truly do challenge you. So that's why I pass them off to the more, this is a complex patient. Left SI strains. Now we have in your manual, Sheila, activities set up for each of these. So before I tell you what they are, we will get there. I'll show you where they are. Your brains are only going to take so much in 2 days. Do you follow me? Even the home viewer. At this point, when I say left SI, it's in your manual. Even if I went there right now and showed you what those techniques are, it's irrelevant for where we're at. I'm just showing you the type of people that have pathological issues that we can associate this B patient to. Hip impingement syndrome on either side probably has an anterior labral issue on the left. On either side. Jason's done a really good job discussing and writing about that. Snapping hip syndromes on either side. Pelvic floor pain. Vulvodynia. Things with anything to do with the pelvis is really what I would consider more of a pathological issue. The more pelvic floor activities you got going on or that are appropriately going on, more likely you've got some pathology in that hip capsule on one or both sides. One or both sides. So, by now, this should look pretty familiar to everybody in the room. By now, that should look pretty familiar. Don't need to go over that again. I don't think, unless you want me to. Now we're going to move all this IR stuff up in the algorithm. We're going to start with this internal rotation. This is called a scissor slide. You lay on your back, you lay on your right side, and you're actually doing a scissor slide where you shift forward and back. It's kind of a breakdown, Sheila. Instead of doing what we did, I put the ball there because you just can't quite get it. Drew, it's just too much for you. I'm just going to put a ball there, and I'm going to maybe put a little roll-up towel between those 2 feet. Maybe not. This one shows none of that. All I want you to do on inhalation, pull back, exhalation, move forward. Inhalation, pull back, exhalation, move forward. All that is in your manual. We just call them the old-fashioned scissor slides. I mean, seriously, I built half of a clinic on that. I mean, there's so much goodness coming from that, scissor slides. We do it on the right side, we can do it on the left side. I know Jen, even in the days we were working together, did some scissor slides. Right side lying, left adductor pullback, okay? Very similar to what we did. The only difference is it's actually about the exact same thing of what we did, isn't it? Is it the same thing, Jen? No band. And we have a bolster here, but not a band. Left side lying knee to knee. Left side lying knee to knee. Now, Jen and I picked 3 things we're going to do in lab today. 3 or 4 things. We're going to do a 90-90 hemi-bridge like we did this morning. You can take your ball. You'll do a shift. You're going to do the Dallas activity. We're going to do that in lab. We're going to do one side lying activity on the right side. We're going to have you pull back your left leg. You can do a right side lying scissor slide. You could do a right side lying adductor pullback. We want you to feel the inner thigh on the right side while you're pushing into the wall with which foot? So these 2 people showed us that.
Inner thigh on the left side.
Excuse me?
Inner thigh on the left side, not right side.
Sorry. So we're going to get you on your right side. We're going to lay you on your right side and do an inner thigh on the left side. Thank you. Then we're going to put you on the left side. And when you're on the left side, we're going to ask you to do 2 things. We're going to have you bring your left knee up towards your right knee. We call that left knee to right knee or left knee toward right knee. It's left knee to right knee when the 2 knees touch. When the 2 knees touch, the right inner thigh will kick on. So I also want you to do a left knee toward the right knee where the 2 knees do not what? Touch. And now you only feel your right glute max and your left inner thigh along with your left anterior glute med and min fibers. Then I want you to go ahead and put a band on. There's a bunch of red bands over here. And you're going to do what we call a left side lying right glute max, which is coming up. Those 4 things we believe in this lab you should feel before you leave this course. Because those 4 things, Dallas, are the 4 things you should go home with and at least entertain using this next week or 2 as you get started in MyoKin. For the home viewer, those would be our 4 solid recommendations because it can be applied to about anything on this handout, up here, when it comes to non-patho and patho. I'll write them all down. We'll have them all written down, ready to go. So those will be the 4 things you're going to do in lab today. And then we got our mate, okay? I'm going to show off the left side lying knee to knee fairly soon. They got the standing supported right glute max with left hip approximation. I know somebody who did that today. Her name was Pat. Okay, so I'm going to just show you the left side lying knee to knee. Lydia, I'm going to use you for this one. Is that okay? Would you mind? We're going to put you on your left side. You don't have to really change anything. What do you got? A pair of shorts are perfect. Come on over here. Take your shoes off. And Jen's going to help me with this one. Lay on your left side. We'll listen to Miss Jen. And we're going to start off by getting some internal rotation from your ischiocondylar adductor for this pathological patient, which she really truly is.
Left side lying knee to knee. Lie on your left side with your hips and knees bent at a 90-degree angle. Your feet flat on the wall, knees together and back rounded. Place a pillow under your head and keep your back and neck relaxed. Place a small bolster under your ankles.
Check.
Push your bottom foot into the wall.
Check.
Lift up or turn out your upper thigh.
Check.
Then lift up or turn in your lower thigh to the point of touching your upper thigh. You should feel your left inner thigh and left outer hip or buttock engage.
And she's trying. Raise this knee, come forward. Hold it right there. Got it? Pivot, push. Do knee to knee. Touch it. The next group on the bandwagon is what? Anterior glute med. And we kind of already did some of this. We had people help us. Drew, thank you for helping us with this one. There's another cool one. Look at this young lady. Janie's laying on her right side. She has her head supported. She's kind of like in Chad's other position. Chad was laying on his left side. Chad, does that look familiar? Kind of like what you were doing. The knee is straight out there, touching a wall. She's laying on her right side. The left knee's on a little bolster. She's getting the left knee to internally rotate, F-A-I-R. And in that position, the anterior glute med and min are going to kick in because she's getting not only hold control from the right side, but she's getting orientation for axial rotation from the left side. And I love this activity as well. We just don't have time to do all this. Lydia, you could do that one. Lydia, you could do any of the first three: repositioning, ischiocondylar adductor, anterior glute med. You could do any of these first three over the next few weeks, and you're going to be in better shape. Any of them. This is your program, because you're patient B. Before I show you the next ones, which are external rotation activities on the right side. It sounds like I'm in love with all these, but I love this activity. Gibby, where are you? Tell me why you love number C. What's number C? If you don't love it, Chad, tell me why you like number C. Tell me, Gibby, why do you like number C? Gibby, you got to get next to a microphone. Could you sit in the chair over here with Chad? The two of you are going to have a little powwow. You two are strength trainers. Two of you are going to have a little powwow. I want to hear a lot about letter C from the two of you. Why do you like letter C? Left side lying, left flexed FA adduction with right extended FA abduction and left abdominal coactivation. First of all, you got to say it. Okay? It's a lot of wording. But what's so cool about this? What's so cool about this? And you guys can't screw up. Tell me in your heart what you see. I'll start with either one of you.
I like it because you're teaching that individual how to adduct. That left knee, finding their ischiocondylar adductor on the left while having external rotation through a glute max on the right.
Concomitantly. For the first time, they can actually feel the two work together. With less effort, Lydia, than what you were putting into this. Do you follow me? With a little less effort. In other words, you'd have to be able to do some of these before he would do that. Chad, why do you like it?
After I reposition, most people can't sense how to lateralize yet if you get them upright. So if I put them in that gravity eliminated position, if you will, make them more neurologically aware of the motor pattern, what it feels like laying down, then they have a better chance of sensing it when they go to stand up.
You both are onto something big right now. I'm going to tie you together right now. What they're both saying is there is co-activation going on with the left abdominal wall, with left inner thigh, thank you, Gibby, and Chad, right abduction. So you're getting right abduction from the femur, FA abduction. Do you see it? Coupled with FA adduction on the left side, coupled with left abdominal co-contraction. And for somebody who's working on stability and weight training and strengthening and power, you just hit the jackpot, provided they can carry that through when they what, Chad?
Stand up.
Stand up. How would you get them to hit the jackpot if they can't do it when they're on their side? That's a really big activity. And those are grade 3s or above for the adduction and abduction lift scores. So those kind of give you your patients who are at a 3 or below an opportunity to experience a 3 and above before you stand them up. Do either one of you gentlemen do number D in your settings? Either one, and tell us what you like about number D. Why both have you there at that table. What do you like? And look at this number 3. It says anterior glute med on the left side. Watch, guys. Anterior glute med on the left side means anything you do in single leg stance on the left side. So these guys are, they're saliva coming out of their mouth, because that's got to happen in a room where you're doing strengthening, right? Push, pull, jump, land. I see landing with number D. Commentary from either one of you gentlemen would be great right now with number D, with letter D. Any commentary?
Kind of like what Chad said, now they have to deal with gravity more than a side-lying or 90-90 position. And you're teaching the brain how to lateralize to the left.
Stop. Whoa. You're teaching behavior in frontal plane load. If you got that handout, just write down. He said you're teaching him lateralization with frontal plane load. Anything else? There's one other thing I want to talk about with this one. Anything else, guys?
I mean, if you've got the right glute max and the left IC adductor to pull you over there, and then you stand up, you got to teach that glute med to help keep you over there long enough so when you go to push off, you don't go back to the right too soon.
Right. It's called delay. It's called speed skating. It's called push off and running. It's called, not only are we teaching you how to lateralize to the left, we're teaching how to fill up space on the right. That person's got to abduct that right leg while they're constantly shifting to the left without the fear of losing their pelvis and what? Falling. They got to center themselves as they pick their right leg up and not fear to fall. Drew, in your world, whether it's by the donut table in the kitchen or by the coffee maker or whatever these nice people are going to do to you in home health, they just need to learn how to shift and pick up that right leg and find that floor without what? Falling. They need to get in and out of a shower. They need to get in and out of a house that's got a couple steps. Laterally. See, going upstairs requires lateral activity. That person's walking up the step. You got to clear that foot for the next step. Love it. So I knew those two men would do this because these guys have been around a while and they probably do more glute med work because of the nature of their work. They're doing single leg stance activity, lifting activity all day long. They have to have people that can co-activate abdominal musculature with glute med. And they see pathology like no other. These people have pathology and they still lift. They still got to get. If you're going to put anybody through a weight program, they better have A on what, Chad? F. They got to have it. That's where the power is. You both know that the power goes completely down when they don't have that F covered up by that what? Covered by that A. Because if you don't have the F covered up by the A, you don't have, Chad's great at this, whole control. Your obturator foramen is not being controlled by anything. You're relying on capsule for a lift. Capsules don't lift you. Obturators lift you. Foramens lift you. Ischial seats lift you. I think we killed that. This looks like left side knee towards knee, doesn't it? What's the difference between that one and the last one you just saw? One says to and one says what? Toward. When you do a left side lying knee toward knee, you're really doing a left side lying ischiocondylar adductor with a right simultaneous right glute max because you never touched that knee. But I'm going to ask you to put a band on and we're going to feel the right glute max. If you go to your appendix and you look at page 31, so we start using the appendix a little bit. Go to your appendix, go to page 31 in your appendix. What program, Karina, are we in right now? What's the title of this program? We are in the Right Glute Max program. And if you see on page 31, bands everywhere. You see the bands on the knees? Turn the page over. I could put a band on that knee on 32 or 33. Turn the page over to 34. There it is. There's the band one. So if you have a little tab, take your little tab and tab that baby because we're going to do that in lab. So see all the things you could do before you put the band on? Let's say a person doesn't even know how to find their right glute max. Well, we'll do all those things preceding that. One banded one that's on page 34. So I want you to know that that's a staple type of activity for the Institute. I always get concerned when we teach this kind of a course and you go home, Sheila, and you got all these techniques, and Jen is so good. Ron, remember, they got to go home and pick a few activities out next week. So what are those few activities? You're going to see some carryover here, trying to hit it really hard. The adductor magnus on the right side. Who helped me with this one? Was it, who was my adductor magnus guy? Dallas, was that you? I don't know, whoever that was, but we said, can you feel your, oh no, it was Chad. It was Chad. This is tough. Now, I will tell you, we have 2 other instructors, and they put some stuff in here, and I put some stuff in here, but I got to tell you, this is a tough baby. That's a really tough thing. And so you're supported, you're on a wall, you're laying on this wall, and you got the left foot underneath of you, Lydia. Lydia, this is something I would not do if I were you. But you got this band around, you're reaching with your left abs, you're centered over that left side, and you got to keep this knee lower than this knee, and then you got to externally rotate this leg out without falling and without leaning back. You got to stay on that foot. Very hard thing to do. I know a few people, that's all they do because they love it. It's what they do to reset themselves. That's a great repositioning technique. All these are medial hamstrings. I'm going to show them to you, and then I'm going to let somebody tell me. I'm going to ask a few questions on this one. First of all, medial hamstrings means that you've got to flex the knee, extend the hip with a 2-joint muscle, and internally rotate it all at the same time. Sheila, every one of those, there's going to be some knee flexion, some hip extension, and internal rotation all at the same time, with the femur being encapsulated by an acetabulum on the ipsilateral side, the same side, which means you've got to be able to pull that femur up by pulling that acetabulum down on the right side. It's like a teeter-totter. So you got to take that teeter-totter, pull that acetabulum up on the left side, cover the femur, flex the knee, extend the hip, and internally rotate all at the same time. And that's called push-off at the end of weight transfers, at the end of mid-stance. We all have to have that at the end of mid-stance. Someone tell me, how is that happening with this technique right here? Supine hook lying, resisted right glute max with left glute med. What's happening right here? How is the hamstring staying on the left side?
That ball.
Ball's one reason, medial hamstring's on there, but what's another thing? That band is providing resistance for IR and knee flexion. Do you see that, Jacob? You got to pull that band back with a hamstring. Which fiber of that hamstring, Bobby? The medial hamstring. And that's why it's number 1 on that handout. And it's in a supine hook-lying state, so you're not completely, you're still loose packed a little bit. What's the ball? Man, this is such a cool exercise because, Sheila, there's a ball and a band on the same patient. These guys insane? There's a ball and a band on the same patient. So there must be a little IR going on someplace and must be a little ER going somewhere else. Does that make sense? The ball's serving as a nice internal rotator for the left side. And how is the band serving as an external rotator on the right side? How's that band being an external rotator on that right side? Because if you pull that foot out to the left and back, you got to push harder in that right side to secure you from internally rotating that right leg. You got to flatten out that arch. That arch is going to be so flat on that board, Jacob, they're going to scream. That's called rollerblading. Because that other arch, that other leg is pulling it over. And you got to say, plant, baby, plant, baby, plant, baby, plant, which is right obturator what? Foramen. Chad, did that make sense? That is a cool technique. And it's not even that hard to do. All you got to do is just put a ball on them, a band on them, and tell them to pick up the left leg. Blow out that air, breathe, no abs if you can avoid it, and try to isolate that pelvis with those muscles that we just went over. I love that activity. What's going on down here, Jen? We got this person standing up, and we got a band on the left leg. They're standing with the right leg internally oriented. They're going to hike that leg up with the right glute max. They're going to pull back that 2-joint muscle, flex that left knee. And because they're in right AFIR when they start, or right FAIR when they started, they'll get a little more external rotation from that right side when they lift up. But it says standing supported right glute max with resisted left hamstring. In other words, I'm loading the right glute max with a little IR. Everybody understand that? I'm turning the femur in a little bit. I'm loading it. And the minute they bend that left knee, they're going to feel the right glute max and they're going to feel the medial hamstring the second they pull that in because of the orientation of the right leg. Janie on that number C, on letter C, is internally rotating her thigh with her foot going out. No resistance. I'm not sure there's a ball there or not, but there could be. Bobby is doing the same thing with knee flexion. She's using a pole to co-activate her left abs, a very high level activity, with IR doing the same thing Janie's doing. This is harder because Janie's supported. She's less supported. She's on a block and on a stick and elevated. This is tough, but I love it. Are there any questions about these examples that I'm showing you? They aren't going to get any more difficult than that because there are no more. This is it. So are there any questions about that at all? Yeah.
Just where does hip extension come in?
For which one?
On A?
You're getting hip extension on the right for sure because there's a little bit of you have to raise up your glutes. It's going to extend a little bit on the right. So the glute max lower fiber, inferior fiber is going to extend your hip on the right. Does that make sense? Because you got to plant that right foot down. I didn't say lift your pelvis. So you got to plant it down. Blow out the air. How are you getting extension on the left? Bobby, I'm going to let you think about it because you're brilliant.
I would just guess from the medial hamstring activation.
With the what?
From the band.
Thank you! From the what? The band. It was coming. I wasn't going to let you stop. The band is providing the hip extension on the left side via the hamstring pull from the band. You see that, you see it, Bobby? That's a great activity. It's a good question. Okay. So page 55, standing unsupported integration non-manual technique examples. These are all great unsupported, and let's read the title, integration activities. So when would we use these and why are they in your manual? Let's talk about this. PRI, standing unsupported integration non-manual techniques. If you were to ask Jen and I, what are some good activities that we could send home with you that would help you integrate what we see down on page 48? Everybody go to page 48 so you know when we would do these. Remember the cheat sheet in 48? Do you see it, Bobby? Bobby, on the bottom of page 48, it says standing unsupported PRI non-manual techniques. Standing unsupported PRI non-manual techniques. What are some examples? And then you come down and it says the word integration. Let's pick a few, okay? So when they get that 4 out of 5, it says standing unsupported, they get a 4 out of 5 and it says no, they don't have a 4 out of 5. And we're saying, Sheila, we want to send you home with some things that I think will give you a 4 out of 5, possibly a 5 out of a 5. What would they be? That's what we're going to show you right now. So when would you stick these, and why are they in your manual? Well, what would those be? Well, here's one of them. It looks like a frontal plane activity with triplanar activity going on simultaneously. This is a snippet. Standing left AFIR. Look how far you've come in this course. We're actually reading terminology that should make more sense. Pat, first course. Does that make sense? Standing left AFIR with resisted left arm pull down. Do you see that band up here, Pat? So he's pulling his left abs in, he's in left AFIR, and he has right FA abduction. So you know there's something going on with that right leg going out to the side. Chad and Gibby told you that's a gold brick right there. It's the same thing we did earlier, but we added a little bit, what with it? Integration. That looks like a 4 out of 5 to me. I can see them laying on their left side, giving me abduction with the right leg, coactivation with the left abdominal wall, with ischiocondylar AFIR control. I can see that. That might make me a 4 or a 5 out of a 5. Does that make sense, guys? That's the first one. What's another one? Right, what are you starting to see with this guy? Frontalism. A lot of frontalism. Right abduction, lateral walking. That's a snippet. Okay? Right lateral walking. Right abduction, foot goes down. I drop my foot down with my left leg. I'm loaded. Shift over to the right. Boom. Do it again. Load. Floor comes up. There, I got it. Reposition. Shift. Do it again. Do you follow me? I'm kind of going a little fast here, but does that make sense? Like that one, page 63. Page 64, right next to it, 62, 63, 64, left stance reciprocal step through. Step throughs and step overs, man, those are good deals for this whole issue of standing integrated work. And she's reciprocating, she's not alternating. She's always keeping her left foot up on that block. She goes all the way over, all the way back, all the way over, flexion, all the way back, extension, all the way over, all the way back. She isn't alternating. It's just left side. Alternating reciprocal non-manual techniques. Let's go back to our cheat sheet, page 48. What does it say, Bobby, on bottom page 48? When you have a 4 or 5 and the word is yes, now circle it. Circle that one. Treatment is coming to a closure. You're circling alternating activity. Treatment is coming to a closure. You can't do much more for them, Ben, because you're going to take what you gave them and they got to now do what with it? Left, right. Army. Ready? You ready? Ready for this? You have people go in the Army, left, right, and what they're doing is right. You're going to see it right away. It's going to drive you what? Nuts. Can you feel it? It's coming. God love you. Good luck with it. Heel stair descents, walking backwards, left, right. All those Army people could be doing that. Correct? Next one, retro walking, band around the legs, glute max. All this would be alternating work. There's more than glute max. This is retro. Can you write this down? Retro, whole control, ambulation. Retro, whole control, locomotion. Jen Poulin and James Anderson wrote a really neat white paper on the pitfalls of, avoiding the initial pitfalls in managing patients with FA instability. And we just kind of covered that reference. And it's in your manual on page 87. And Bobby, it's so cool because the terminology is going to make a lot more sense now. And they broke it up. You see where it says bicep femoris, ischiocondylar adductor. Looked at it last night. Anterior glute med, posterior left ischial. They took every single thing and they gave you appendixes to go to look at those examples. It flows really, really well. Really a nice reference for you. Right after the reference that Mike gave you on the adduction lift, the pitfalls of doing that incorrectly or some things you want to remember. All three of these people did a wonderful job for this Mile Kin course. All three teach it. Okay, I think what we're going to do is we're going to stop right there, and I'm going to come back to these things, these syndromes, after we have lab. Okay? You guys are awesome. We're doing a great job. Are we going too fast? Is this kind of making sense? So you shouldn't go home, Bobby, overwhelmed, right? Shouldn't go overwhelmed. We got a patient A, we got a patient B, correct? We're going to Come back and look at those two things right after the break. Take a 10-15 minute break, and we're going to do a little lab, and then we're going to end up with some syndromes. What you got going on here? Do you feel the left hamstring? Mm-hmm. Okay. What else are you feeling?
Left adductor.
Good, because if you didn't, all we'd have to do is shift this leg up. Okay, hold it right there, got it? Mm-hmm. Now, bend the knee and put your foot back on there, but don't drop it. You sure do. Did you see how I was at adductor pullback in midair? So
I was saying we cue that in clinic, but I didn't see it in the papers.
Yeah, so yeah, you want to cue that.
Okay.
The one where it says the scissor slide, we just didn't get it all covered, but you can do a scissor slide right here. I put a ball here, and you can do the same thing. I'm going to grab a ball. I want you to feel it, okay? I want it on camera too. So I'm going to grab a ball. So with that ball here, and you don't even do a tilt yet. Just feel the feet on the wall. Feel the back of that calcaneus. You feel it? Push on the wall. Good. Pull down on the wall. There's that posterior pelvic tilt. Okay. Did you feel that? Jelly belly, right? Now in that position, bring one knee up. Bring your right knee up. Okay, you should have felt this push harder, okay? Hold that, got it? Now, pull this leg up, but don't let go of this side. Pull this leg up and this leg down. Now you should feel that inner thigh.
Yeah.
You feel that? But don't let go of that. Hold that, bring this guy down and that guy up. So we're doing a scissor slide in a 90-90 position without you losing that inner thigh and that hamstring on the left side. So when you then hold that, and you take this away, and you straighten your right leg out, now you got your inner thigh going on and your hamstring, and that's what you guys are doing in the clinic. Go on and off the wall now with your right leg. Just touch and go back on up. Do you feel your left medial hamstring?
Yeah.
Do you feel your left inner thigh? Okay. Do you feel... What else do you feel? Do you feel your calcaneus? Do you feel your foot on the wall? Okay. What else do you feel?
I think in a negative, I think my gastric on my left is trying to kick in.
That's okay. It's kicking in. Anything else? Good.
Really, it's just those.
Good. So you didn't say anything on the right side, which pleases me.
Okay. Yeah.
Okay. Good job. Good
So
job.
if they're not feeling hamstrings, that's when you would move that left foot out.
Yeah, if she couldn't feel her hamstrings on this side, I would do one of two things. One, and I'd get her to blow out that air because she's not breathing. But I watch her. If she could feel her hamstrings, she's got to start breathing. If she cramps up, she's not breathing. So you got to keep her breathing. Number two is I'd want to have her get in more IR. I could do this. I could do that. And I'd have her push down, go up, push down, go up, and now she's really got to feel her hamstring.
Yeah.
I mean, I'd myokinematically bias the muscle position. Do you follow me? I would bias you if she couldn't feel it. And you'll have people that can't feel it. I guarantee you, Bobby, they won't feel it. And if this is all they do, then that's a good way to start. That makes sense at this point? Why don't you go into the other three? Do this. Get on your right side now. Get on the right side. I'll get your phone. You just dropped your phone. And over here, I want you to do a right side line. Just use this for something there. Here's your phone. I'll lay it right over. I want you to do a right side line. I want to make sure I do this. Adductor pullback. So I want you to pull this baby back. Do you follow me using your left thigh? So help her with that. What would you do here?
So the first thing.
And we could have I'm just going to tell you, we could have a bolster under here. Do you follow me? We could put a bolster here, I mean. She's laying on it. I'll grab another one. Want to grab that one over there? I just want to hear what you're going to do here.
Have you done the pull-up? Yeah. Have you done this?
You're stable.
Okay, so let's start with a scissor slide first. Okay, put the ball between her leg. Okay, and have her shift all the way back and all the way forward. Okay. Now, instructor, what are we going to do when we go back for adductor pullback? What would we do?
Inhale.
Well, let's first of all yes, you would. But let's have her push the right foot into the wall. So she's going to push her right foot into the wall. What's the next thing we might ask her to do?
I would guess just squeeze in with the left
Squeeze
leg.
it. Find your left inner thigh. Find the left leg. Squeeze in. Do you feel it? Feel that? Okay. Then what are we going to do?
And have bring the
Pull back.
head back while maintaining the squeeze.
Yep. And you could ask her to do that on air in. So when you breathe in, pull back, go ahead and blow out and squeeze.
So
Pause.
is the idea with this one you stay back there and you just bring it back,
Yep.
exhale, and then you should try to bring it back
Now,
forward?
that for this technique, it is it's called an adductor pullback. Or you can do this. Relax. Let's do it again. Ready? Here we're going to do a scissor slide. Ready? Pull back. Breathe in, blow out, relax. Okay, now we're doing a scissor slide. Or on air out, she can push all the way forward. Blow out, blow all the way forward. That's the right side. Breathe in, go back. You follow me? We're just getting movement. We're just getting a rusty joint to move again. We're just trying to get things to move. Does that make sense? So she takes a breath in. You feel that when you blow? Now let's see what happens if she reverses. This time, pull back when you blow out. Breathe in. Blow out. Pull back. Blow out. Do you feel how you're now getting more back? Because you're getting, when you blow out, the abs are on. Now you're stabilizing the back that you don't want stable here. You want to let it go. Did you feel the difference? It's harder to come back. Let's see if that's true. Breathe in. Blow out. Pull back. You feel that? Everything tensed up.
Yeah.
Relax. Breathe in and pull back. See the difference? When you breathe in, she's filling. When she fills, everything's expanding. Okay, that's a right side lying left adductor pullback. Let's flip her and come on over here. And why don't you show her a left side lying knee to knee versus knee toward knee.
This goes under both of them, right?
I would put that under both, yeah. Yep. I'll get out of your way. You come on over here.
So,
Okay, here we go.
so the first thing that I would need you to do is punch this forward. Correct.
Okay. Yeah.
And so you're going to basically keep this hip over hip and then rotate this up. What are you doing there? And then I want you to we'll bring this all the way up to this knee. So bring your left.
And if she can't, okay, good work. And so you're going to say, think, turn. Let's go back down. We're not going to worry about breathing, just breathe. Okay, let's do this again. Go back on down. Okay. Think, turn. Think, turn. So you're going to use this foot, push into the wall, the left foot, push into the wall. Use this as a pivotal point. Think, turn. Turn, stop. Think, turn. Turn this towards that side. Very good. Stop. Okay, relax. Go back down. Now, we're doing this to get her to feel her glute med and min and ischiocondylor adductor on the left side. When she's doing this, we want to do everything we can to make sure that she's not using her back to do it. So what we're going to do is we're going to ask her as she's turning to move her right knee forward. If she can move her right knee forward a lot and still do it, that's awesome. But a lot of patients won't be able to get that knee that far forward. So what would you ask them to do at that point? Come back. Don't go so far forward. So we want to have you think turn, and when you think turn, come forward. So think turn, come forward. And you're doing a great job, Colleen, okay? So let's do it again. Think turn, come forward. There's her right glute max. Got it? Lower it a little bit. Now, bring your knee on the left side, think turn. There. Oh, that is tough. Do you feel that? Why don't we do this? Go back down. Think turn, don't go so far forward. Just go right there. Now turn that left knee up. Did that go easier?
Yeah.
So all I'm saying, there's a sweet spot that everybody has that you're trying to figure out by having them think turn and go forward. If they can't pick it up, back it off.
Is that because she can't handle that much internal rotation on the leg?
Bingo. She doesn't know how to control, she doesn't know how to move an A over an F with that much AFER on the right. It's too much. She can't do it. So back her off. Let her find that sweet spot before you go to another technique and give up. Give her the chance to do this. If she's going too far back with this leg, then you can't pick this technique because she can't handle it. Exactly. So you can start with knee lined up and just think turn when she comes forward a little bit. Stop. Got the floor? Got the floors? Okay. Got it? Hold it. Now think turn and turn your bottom leg up. And she can do that. She can. Now bring it up. Let's go all the way and touch. She still can do it. And touch a little more. She still can do it. Did you feel that? You still could do it. But as she approximates that other side and she starts to pull the right adductor in on this side and she touches, she may not be able to do it, which means you got her advance too far into what? Left AFIR or right AFER. Am I making any sense?
Yeah.
So you want to go, you just kind of play with it. Think turn and rotate. Think turn and come forward. Think turn and come forward.
But do you want them to be able to go out
As far as they can, without losing control.
and without
Without losing control. Without losing whole control on the side. Right foot, pivot. Right AFER. Got it.
Yep.
Now, think turn. And she's doing pretty well, but she's struggling.
Yeah, this is hard.
So I would say, okay, stop, start all over again. Right there, try that. Now, go, perfect. Now, did that go easier?
Oh, that's so
Isn't that cool? Now you got it. So you're finding that, you're tuning that sweet spot in, and everybody's going to differ. I can't write, go 2 inches, go 4 inches with this patient, go 1 inch with this patient. You just got to play with it.
Right.
Now that was knee to or knee toward knee. Grab a red band. Let's put it around her knees. Let's do the very same thing, and we're going to use the same principle of thought, okay? Think right glute max now. So think turn again. Here we go. Good. Extra, stop. Do you feel, got it right? You get your right glute max? Okay. Now let's see if we can find, is it burning? Got it?
She's activating very well.
Okay, now take your left knee and bring it up and think turn with your left knee coming up. Is it still there?
Yes.
Do you feel the left inner thigh yet?
Not,
Okay, then move your right knee forward.
yes.
Now you got your left inner thigh, right? Do you have your right outer hip? Do you feel your left anterior glute medium in?
Yes.
That's cool. She fine-tuned that. Do you see how I find? That's all myokinematics. I'm moving muscle in a kinematic position for to fine-tune the rotation and all 3 planes that I want from the muscles that I'm trying to get. By fine-tuning her, I means I'm moving forward or back to find it. Do you follow me? I'm moving forward or back to find that sweet spot. And you're on right now and you're doing well. And you're breathing. That would be your home program. That makes sense to you? So do it one more time, and then I want her to do it for you, and I'll leave you guys go.
Okay.
So go ahead.
You want to talk?
Tell her what to do.
Okay, so go ahead and punch this knee forward a little and kind of roll it out and up. And then hold it there. And then lift that bottom leg up off the table a little bit. And what are you feeling?
Right glute max. I feel my inside left thigh and my left knee.
Do you feel your left hamstring? Then push the right foot in the wall more.
The right?
The right one in the wall, because she's got to get hold control. She doesn't feel the hamstring yet. If you still don't feel it, let me know. If you don't feel any hamstring, let me know. Okay, then you got to go a little, then we got to get more, and it's going to be hard to find, but let me help you out here. You okay? Let me help you find it. Okay, so now to find the hamstring, I want you to do just what you're doing. Bring your right leg forward, but you got to think turn on the left, because you need your medial hamstring to do that.
Okay.
So see, I'm just playing with her. Okay, let's get the right glute max, get hold control. Okay, tell me when you got your right glute max. Is it on? Okay, don't lose it. Pushing the wall. You got hold control on the right side?
Yep.
You know where you're at right here. See, you got it. Okay, now keep your foot pivoted on that left. Okay, and turn that left knee up towards that right glute max. Good, good. Now push the left foot in the wall.
Okay.
Now keep the left hamstring. Do you have it?
Yeah.
Now bring your right knee up more.
My right.
Right knee. Did you lose your left medial hamstring?
A little bit.
Push your left foot in the wall more.
Okay.
Do you have your right glute max?
Yes.
Do you have your left hamstring?
Yes.
Do you have your left ischial seat? Ischiocondylar adductor? Do you have your left anterior glute medium in?
I do.
Mission accomplished. Do you see how I'm fine-tuning her?
Right.
Yeah.
I'm just fine-tuning everything up. It's so cool.
Yeah.
You're fine-tuning it.
Yeah.
And I know that's complex, but do you see how we can fine tune that radio station just by what we're doing? Just by
So
what
we
we're
need to
doing.
make sure we get that left one harder to make sure the hamstring's going during that.
Correct. Now you got to remember, you guys sat through this course a couple days. You know what to do. Your patient's not going to have any clue. I may just start with left hamstring a lot, because if I do 90-90s to get my left hamstring a lot, that will come faster with this activity.
Right.
So if she can't find her hamstrings, I'm going to say, whoa, I'm going to back off. I want to do more hamstring work, maybe upright, standing work, maybe seated work. I want hamstring. Don't let the baby wash down the river with the bathwater. You got to keep the baby. So in other words, don't drop off the hamstring. So if you're doing this activity and your hamstring's dropping off, you got to pull it back.
Okay.
You follow me? But we're doing 4 activities that are great, but don't lose the hamstring.
So the easiest way to cue that is to have them push that left foot into the wall.
But you got to have whole control on that right side, because that keeps you pushing over
While
that
having-
left side.
yeah, while-
She can't find her hamstring?
Nope, neither one. Well, I just gave her her left one.
Oh, well, good, Chad. What'd you do? What'd you do to give her?
His foot off the wall.
Okay. Did you find it?
Yeah.
Well, good job. Can you show it to us? You know, these yoga instructors they are so challenging. You know what I mean? Okay. Okay, what you could do is you could have shifted her. Which hamstring do we want? The left one? You could shift her. Did you shift her a little bit? Okay, let's go back on down. So let's do just what you did and learn how to shift with that ball, okay? So go ahead and push down. You're doing a great job. Secure that, okay? Raise up, stop right there, breathe. Take a breath in and blow. I want all this off. I want that off. Do you have those hamstrings now?
I think so.
Okay, well, let's make sure. Take this away. You're relying on this way too much. Right? Now you got your feet on that wall.
Okay.
Now what did that do for you? Do you feel the difference? There's no there's nothing there.
Right.
You have to push on that wall. Do you feel that? You got your glutes? Do you have hamstrings right now?
No.
Okay, here we go. Take a deep breath in. Blow out all that air. Sheila, blow it out. Squeeze that ball, just like he had you. Okay, now keep breathing, but just leave this off. Now shift a little bit this knee in the air. There, stop right there. Good job. Squeeze the ball with that left inner thigh. How about now? Do you feel the hamstring?
Yes.
Don't lose it. Did you feel how there was more weight now on this foot right here? Now, Sheila, do not lose this foot. I'm shaking it. Is it there?
Yep.
You will not lose your hamstring if you have that. Is it still there? Okay, take another breath of air in. Still keep that foot on that wall. Blow out the air.
Still on, or are they off?
They're off.
Okay, just keep it on the wall. Keep it on the wall. Pick your right foot up.
Get out.
Keep your right foot off the wall. There. Do you feel that hamstring on the left side? Or okay.
The outside of my knee screaming at me.
Okay, go back on down then. Okay. All right. So if you're feeling the outside of your leg screaming, your VL is starting to take over, and you're starting to use your IT track. So you cannot pick up that right foot. You do not have the ability to pick up that right foot. So we're going to do more work with you shifting. We're still going to keep you here. So let's do the same thing. Take a breath of air in. You're doing a great job, but we cannot pick that right foot up off that wall. Go up in the air, raise up. Have you done knee towards knee with her yet? Okay, got it? Got it right there? Squeeze that ball. Got it? Squeeze that ball. Shift it right up, stop, come back down. Shift the left up. Good. Now, is your outside left knee still yanking at you?
No.
Shift the left one down, shift the right one up. This is called a 90-90 scissor slide. Feeling it?
Oh, now I feel it.
The outside leg?
The knee started to yawn.
Okay, go down with
I'm
it.
not pushing the
Yeah,
feet.
yep. And shifts. Stop right there. Stop right there. Is the outside knee killing you?
Yeah.
Okay, let's go back on down. Get closer to the wall. What's the next thing we can do if they're outside? I love this. What's the next thing we can do? Well, how are we going to shut this off? What's the next thing we're going to do? Take this foot, put it right there. Here we go. Here we go. Let's give you a little help. Oh, you're lifting with your back. Take a deep breath in. Blow out all the air. There. Got the hamstrings? Got them? Okay, is the outside leg screaming at you? Okay, hold there. Take that knee, think turn, and squeeze that ball. Think turn. There, right there. Do you feel the inside thigh?
Yes.
Okay, do not pick this leg up. Do not pick it up because we're dead if you do. Do you have it? Shift the right knee up. Do you still have the left inside thigh?
Yes.
Okay, did you have any pain on the outside of that left knee? No. That's the only thing I can do for you. Do you feel that? Jelly belly. And you're going to feel differences in your pelvis, I'm telling you. But did you see how we shut that off? That's the only thing I can do for you right here, is that. Okay. Until you get that, it's going to be hard to do knee toward knee, right side, left side lying right glute max. It'll be hard. Left side lying knee to knee. It'll be hard. Right side lying left adductor pullback. You might be able to get, but definitely 90-90 left hammy bridge is where you should be starting. With that being said, lay on your right side. Let's do a left adductor pullback. Let's lay on this side. You want to grab a pillow for her? Katie, this is a great demo. Here we go. Okay, put your ball between the leg here. Got this done? Here we go. Chad, come on over here. I'm doing all the talking. Show this lady how to do a right side lying left adductor pullback. I'm going to step out of the way, and let's see how he does with this. This is a great demo. Tell her what you're going to have. Now remember, we have a real difficult case here. Right. She cannot find her left hamstring.
You feel your right.
And if you screw up, I'm going to help you. Don't worry about it, okay?
Well, I'm not worried about that. Feel your right heel on the wall?
Yes.
Don't lose that. All right, and you feel the ball on your left inner knee? So on inhale, you're just going to let this knee glide back.
Good job.
And
Good
on
move.
exhale, keep that back and just slightly squeeze that ball. Exhale out your mouth. Now, don't lose that.
Do you feel that? Sheila, what he's saying? Your inner thigh, in your inner thigh. If you feel the TFL, that's all he wants to know. Do you feel the TFL or do you feel the inner thigh? Do you feel it working? TFL for sure? Okay, let's do it again. Chad, what are you going to do now?
Stay right. Just going to put this foot a little higher.
Bingo. See how smart he was, man? He's saying, I got to get that TFL to not internally rotate, so I'm going to internally rotate the femur for it. It can't do it now. Okay? So he internally rotated that leg.
So
he could put what right here? Chad, I'm helping you out. He could put a bolster right there.
So just rest this foot here. So you still feel your right heel on the wall?
Yep.
So inhale, shift back. Shift back. No.
Oh, on
Start
inhale.
over. Shift back. Exhale and slightly squeeze that ball. Don't squeeze very hard. And then inhale, shift back again. And on exhale, squeeze. So when you squeeze, can you sense this is coming forward when you squeeze? You see that?
Do you feel? Go ahead.
So when you squeeze, try to keep this back.
Nice job, Chad.
So let's just start. Just reset. Just here. Just shift this.
Pinching?
Oh, yeah.
Here.
Okay.
Just move this back and forth a couple times.
And if you're pinching, don't forget the right foot's got to stay in the wall.
Okay.
Stay in the wall.
So here, just rest this hand on the floor. We'll start over. Feel your right heel.
There you go.
Don't lose
Don't let
that.
it go.
There you go.
Did your pinch go down on the left?
Yes.
Okay. Did you hear what he said?
Don't lose
that.
Just rest this knee down.
Good.
Okay. Still have your right heel.
Mm-hmm.
Okay. Inhale, shift back. Shift. You didn't start over. That's right. Still got your right heel?
Yep.
Okay. And keep that back.
See how much
on
easier
exhale.
that went for her? As soon as she had that right
You
heel,
gotta
that
exhale out
right,
your
see
mouth.
that?
Keep that back. Still have your right heel?
Uh-huh.
Good. Inhale. Exhale, slightly squeeze. Inhale.
I love it. Are you pinching as much?
Don't squeeze there.
Are you pinching as much?
Not as much, huh?
Okay.
Are you starting to feel this more in your groin or inner thigh?
Yeah.
Little
Okay.
Some?
Good.
Yep, some.
And
This
that's
starting to
where
kick
you should start. And so he could keep putting more here. Let's go a little higher. Chad, do you mind, Chad?
You got that?
Chad, you're doing a great job. What he's saying is, don't lose hold control on the right side and cover this femur up with this acetabulum by squeezing without losing hold control. That's all he can do for you. He can't do anything more for you. When you breathe in, that's what he's saying. So let's try it again. The ball is still there. You shouldn't be pinching any more than before right now.
Now, you don't feel this right now because we made this higher, do you? Do you feel this at all?
It's clear under here and.
Perfect.
Yeah,
Oh, good. So let's get the right heel on the wall.
Okay.
And just rest this knee down. Inhale, shift back. Exhale and just slightly squeeze.
Did that feel like it moved more easily for you, Sheila? Do you see what he's doing? He just allowed you to move that acetate. Oh, Sheila, feel that? Did you feel how much further you shifted back?
There you go.
I don't know if I can go back anymore.
That's
You
all right,
can't.
It won't.
So we're at a point, guys, everybody in the room watching this, there's a technique in your inhibition section we're going to come to right now that's called a posterior capsule release or restoration technique. We could put a bolster here and we could do the same thing and create distraction in this capsule because you're too snug, you're too tight. He's really working hard to help you get it. So why don't we get done here, sit down, and let's go over those inhibition techniques because I'll bet her internal rotation would have been limited. Did anybody check her IR yesterday? Anybody look at her IR? Was it limited? We're going to get more IR. He can only do so much. So let's give her more IR. And I'm going to come over there, you know what I'm going to do, but I'm going to come over here and I'm going to show you what we could do, and then we'll talk about inhibitory techniques to get more. You did a great job, Chad. Okay, I could take a smaller bolster. Is there a real small one over there, Chad? Smaller than this one? Because she's so petite. I'll take it. I'll take it. You know what? I'll use this one. I'll use this one. Open up for you. Just clam it up. I could take a bolster and put a bolster between your thighs, way up next to the groin, way up here. It would be thicker than that. And you would go back, and I put a bolster here, and I would, on air in, I would be pushing down.
That feels better.
Doesn't that feel cool? Yeah. That's what you need. You don't have enough room to get back into that socket. Doesn't that feel much better?
Yeah.
That's what he's trying to give you. But he can't get it because you're too tight. So I would put that bolster here, and I would do the very same thing to help you. Oh, look at that. Look what that did.
Yep.
Bam. Do you feel that pole back here?
Yeah, when I'm feeling it, ischial tuberosity, right?
Do you remember the lady from Kansas yesterday that had her finger pointed right here? Remember that picture? I said she had those wide hips, and we couldn't get her to adduct. We had the bolster in that groin area. Do you remember that picture yesterday morning? And we were trying to give her more posterior capsule movement, room. That technique I would use for you. I'd open that up because he can only give you so much. He's helping you with this. You're doing a good job with your inhalation activity, but you can't quite get back there because there's no room in the end for that femur. You can't get it back there. So we got to distract it as you breathe in and get you back there. You're going to pull it back. I may be assisting you to get that back. So that's not only an inhibitory technique, it's actually a stretch of the posterior capsule. Does that make sense?
And when I strengthen my hamstrings, eventually then it should
It should just pull right back in there. But right now, you kind of look patho to me. You look like you kind of look like this front of your hip capsule's too loose. And the back of your hip capsule's too tight. And he's struggling to get you to get that. He can only do so much. He gets to a point and he says, you know what I want you to do? I want you to go home and I want you to show this. I want to show you this inhibitory technique for posterior capsule. Let's go back, pick up the posterior capsule. Just because of you right now, we'll kill that and show you what I would do. And this is very common. This is a very common problem on this side. Can I show you the other side? Flip around. Did you guys look at this side? Look how easy it is over here for this side. Might not be, but let's see. We're going to just reverse. We're going to just reverse. Go ahead and do it. Okay. Take a deep breath of air in. Push this left foot in the wall. Okay, ready? Breathe in. Do you see that? Do you feel that?
Yeah. It's still gripping.
Okay, but do you see how much range of motion you have there? You need that on the other side. Do you feel how far back that went? Can you sense that?
Right. Mm-hmm.
We need that on the other side. Can you sense, go all the way back, how much easier I can get you? Am I correct? Push down. Did that pinch as much?
Not as much.
No. And if anyway, we need more of that on both sides, but
And
we
this
never.
is the snapping hip.
You're popping in and out because you're snapping you're snapping more on this side because there's more weight going through that hip. But you probably could snap on the left side if I put the same amount of weight through that hip. Both of these hips are probably patho.
Yeah. It snaps when I roll over at night.
I
so it wakes
believe
me
you. You're
up.
too loose. You're too loose. You're orienting yourself around that right side, and it's snapping.